Good morning, Priya. It's so lovely to be able to spend some time talking to you today. You are a true role model of a physician scientist, and I'm looking forward to talking to you about your research program and your clinical program. So thanks so much for being with us today.
Thank you, Swati.
Priya, could you tell us about your incredible science research program and how you have approached, as a physician scientist, tackling disease mechanisms and treatments?
Swati, I've been at Duke now 31 years, and I think that in itself has lent a lot of longevity in terms of understanding rare diseases, which is the focus of my clinical and translational research. So having seen patients earlier and understanding there was so little known, and then as they grew older, some of them were lost to follow up or were lost because they passed, actually led me into this journey of looking at the bench and the bedside and trying to see how to work both of them together so that we could advance patient care. So I focused a lot on patients with glycogen storage diseases and lysosomal storage diseases, and learned that listening to the patient very carefully is the answer to a number of unknowns. And I can tell you this in so many instances where you hear from a family and then you ask the question to the next patient and the next, and it starts emerging as a theme. And it's usually otherwise overlooked because there are other more pressing issues that the family is dealing with. That's one aspect. The second is, I think the word team science and collaboration is something I have done through the years, and you find good colleagues across campus, across the world, and collective team science really has paved the way for rare diseases. And I can tell you this firsthand, is we are here today only because of so many individuals at our own institution that have trusted and put in their own time as we've tried to uncover issues and then try to advance them into therapies.
Thank you, Priya. I love that you talked about the patient and families and listening, right? And how that can really inform what's necessary to do for how we take care of patients, but can inform the science that's done too. And you give a lot of credit to people around you, but you've really been a leader in this field. You've been able to take clinical genetics and really establish this cycle of discovery where you're taking things from the bench to the bedside and back. Your work in Pompe disease has been incredible and has transformed the lives of so many patients and families. Can you talk a little bit more about some of the diseases that you've been studying and how you've really gone from bench to bedside and back?
Yeah, Swati, and I take a lot of pride in saying that, you know, people often talk about bench to bedside, and I can say that we as clinicians understand the importance of taking it from bedside also back to bench, and we've been able to do this successfully. And I can just start for a moment even with how the Pompe story emerged. Is I was in training at the time, and we had a patient with infantile Pompe, and this was in the early 1990s. And the only answer we could give families was, love your child, take your child home. There's not much we can do, and they're going to pass within a year of life. It was after returning from the funeral of one of these children that I think Dr. Chen and Johan Van Hove, who was a trainee at the time, said this cannot repeat itself. And that's when the team science started of how do we make a difference and make a change. And so that's my first message, is you actually need something, that brings you to work every day. And for me, it is the story of these patients and the unmet clinical needs. And so as we started this journey on Pompe, we recognized that with enzyme treatment, which Duke is known for, and we developed a treatment, but very quickly what I also learned was there are so many factors which are involved that we need to take into consideration. very simplistically, even the immune response to a therapeutic protein is important. And I remember in the early days when I used to bring this up, there were some senior scientists across the globe who would not really agree to the message. And then it took me from bedside to bench, to show that this indeed does make a difference. And today we have what we call short courses of immune tolerance induction, which has made its way into the package label for L-glucosidase alpha. So that was one part of the journey, and this has transformed the lives of those children who otherwise would have been deceased. The next step was also realizing that a few days matter. I started seeing that if you started enzyme therapy in a rapidly advancing disease, just a few days later actually could result in an outcome that resulted in either the ability to walk or not to walk. And so that took me back again to the concept of newborn screening. And so I advocated for newborn screening for Pompe, which is now on the recommended uniform screening panel and was the first lysosomal disease to make it on the panel. And today we have MPS 1, and I recently was part of the committee for submission for mucopolysaccharidoses type 2, and I'm proud to state that that's the other one now on the RUSP or the recommended panel. So I think this journey of crosstalk between laboratory science and patients has really allowed us to advance. And having put so much time and effort into one rare disease, I want to assure other families and other patients that have not neglected others, because again, it's the learning from one which takes you to the others. And currently we are focusing on other hepatic GSDs that have been passed off in the past, by myself included, in the general literature as benign. The reason we've called it benign is that maybe we've not followed these patients long-term, they're lost to follow-up, or there are silent findings at the level of liver, which then unmask as the patient gets older. And so our current focus is on some of the hepatic GSDs, like glycogen storage disease type 3, type 4, type 6, and type 9. And I think there's a theme that's emerging, that if you have storage material in the liver, you can end up with progressive liver fibrosis and cirrhosis and a risk for hepatocellular carcinoma. So this is currently an area of bedside to bench and bench to bedside using animal models, both small models as well as larger models. We have canine models, which are naturally occurring that we've identified because we work closely with the diagnostic laboratory. And so we are able to use these models to help us understand what's going on and then put it back into patients and trying to see if this holds true. So that's the current focus. I'm very excited and trying to train the next generation of physician scientists, including some incredible grad students and undergrad students right from Duke, and some who come from UNC, just because they want to make such contributions to the field of genetics.
It's incredible, Priya, that, when you think about, you see a patient, you're informed by the patient, your emotions are informed by the patient, which led you to study Pompe disease. And, to be able to, in the cycle of discovery, understand mechanisms, develop therapeutics, influence policy, to be able to have newborn screening for Pompe and other diseases, and also training the next generation to continue this cycle. It's really incredible. Moving on, can you give us your sense of what the next 5 to 10 years looks like in clinical genetics and translational genetics?
This is I've been thinking about this quite some, Swati, and we've considered, first of all, many of our single gene disorders as monogenic. And I think, again, the field has taught me through years is that there are so many environmental factors, the role of epigenetics, the role of genes involved in pathways. And so I think even for our single gene disorders, the concept of omics has definitely taught me how much there is to understand. So when I say omics, I mean lipidomics, metabolomics, proteomics, immunology and immune phenotyping, I think that has given us insights into disease progression, but also in terms of therapies. And as an example, if you even think about gene therapy, when we think about AAV gene therapy, we're now really realizing the role of the innate and the adaptive immune system to the AAV gene therapy, not just to the capsid, but also to the transgene. So that's one aspect that I'm thinking about. The second is right from diagnostics. We often have a patient that comes in with a phenotype, but when we do sequencing, we identify one pathogenic variant and nothing on the second allele, but yet the phenotype is very compelling. So again, bringing us back to using newer tools and modalities to uncover what this could be. And this has been, again, in collaboration with many at Duke, including Tim Reddy, Greg Crawford, and you included, in trying to uncover, what that second pathogenic variant could be. And it could be in a non-coding variant, which was not known. However, if we only relied on molecular, we would never be able to solve the puzzle. It's because we look at it from a complete picture of biochemical along with molecular and work again collaboratively to advance this kind of understanding. So I feel that the tools are available, but without the clinician scientist being a central part of this, those tools are only that useful, because you and I can be very clear that this phenotype really does fit into a particular condition, but the molecular does not add up. And so I think using those tools, and I think that is the next foray, as I see it now, another exciting time. And as we do this, and as we do genome sequencing, we're uncovering so many other variants in the gene of interest, but also in other genes, which could tell a whole story of synergistic heterozygosity or other pathways that are involved. So in my small world, this is the way I'm thinking about genetics and genomics at this point.
That's wonderful. I mean, I think it's an expansion of your concept of team science that you began this conversation with, but the team science has exploded that much more, and we can leverage evolving molecular technologies and omics, computational biology, collaborating with molecular geneticists. But at the foundation of this is how you think about the patient, the families, and really making an impact and training the next generation. It's amazing, Priya. You're inspirational. I hope that others can see this amazing path that you have led and what influence you have had on individual patients and families, as well as the field broadly of science and rare diseases. Thanks so much for your time.
Thank you, Swati.